Okay, hi, this is Elliot Fishman, and welcome to our latest talk. And this is going to be a really interesting talk about the abdominal aorta. We're not going to speak about abdominal aortic aneurysms and type B dissections or how you repair an aneurysm, who has a stent, or the complications of endoleaks. But I'm going to speak about the branches off the aorta more than anything else. I will speak a little bit about some aortic issues, but it's really the branch vessels we're going to speak about. We're going to look at aneurysms and dissections and vasculitis and how we are picking these things up incidentally these days and how you need to look at it and how you really need to think about it. So I think about CTA of the aorta. I was putting together some talks, and it made me think about advantages. Nothing really brilliant, but scan protocols are reproducible and less dependent on scanner and scan operator. So we can do this in small and large hospitals, in the hospital, in outpatient centers, as well as the ER. Patient cooperation is minimal as the scan times are measured in seconds. The ability to look at vessels and bowel and soft tissue and different organs on a single acquisition. And again, we spend a lot of time thinking perhaps about organs like the liver, the spleen, the kidney, but not really thinking all that much about the vessels. So we need to really make sure we do think about the vessels. CT, particularly with thin section CT, millimeter or less, you have high spatial resolution for both normal and for pathology. Post-processing, particularly 3D imaging, even things as simple as MIP imaging is critical in all cases. And our ability to detect pathology beyond the area of interest. And what I mean by that is you may be looking at the liver and then you see some abnormalities in the SMA or in its branch vessels. And so you're really pulled away from the liver to the renal artery. Again, the idea of looking at the entire volume. And again, the fact it's available in the ER and everywhere else makes it really good. Now, one of the things, of course, this idea about looking at bowel, looking at organs, and looking at vessels together becomes very critical. Here's just a simple example, and I'll just make a few points with the next few slides. Here we see in the cinematic rendering thickening of the terminal ileum and very prominent vas recta, the so-called comb sign, fibrofatty proliferation due to Crohn's disease, and the prominent vascular mapping seen nicely on the MIP and especially nicely shown on the cinematic rendering. The high spatial resolution was nicely seen on the prior case looking at the vas recta, but here's just two more examples. Here's a patient with vasculitis with focal dissection in the SMA and irregularity of distal branch vessels. And here's another patient with Crohn's with very prominent vas recta. And these multiple vessels, which are very prominent due to the patient's underlying Crohn's disease, you can't even measure these, right? These are sub-millimeter vessels, but look how we can see them and line them up very nicely, that so-called prominent vas recta. Or in this case, we follow vessels from the coronal view, and you see thrombus in the patient's SMA, which led to ischemic bowel. But here you can see it again, cinematic rendering. There's the vessel, there's the cutoff. Here it is again when you look at it on the sagittal view and on the MIP imaging. So 4 different ways of looking at the thrombus. It does make the point also, this is a subtle finding, but if you look at all of the images, maybe you won't see it on all 4 individually, but you'll pick it up at least on one of them and you'll make the correct diagnosis. And again, things that relate to the vessels. Here's just a simple example of the renal artery, which could be causing a UPJ due to location, but it's a normal vessel. It's a location that's the problem, cutting across the UPJ. And here was a hypertensive patient with a renal artery aneurysm. Oh yes, there are a few small splenic artery aneurysms calcified in part, but the patient's hypertension was his renal artery aneurysm. In this case, they were looking for an adrenal pathology for the hypertension. Also wanted to look at renal artery stenosis, but it was an aneurysm that was the culprit. Or in this case, the details we get, look at the patient's renal arteries in both case 1 and case 2. You see the beating in the right renal artery here. You see a little bit on the left. You see in this case, extensive on the right. The left looks pretty good. Volume rendering and MIP imaging, and this was classic fibromuscular dysplasia with beating. We also know in this patient with hematuria, we looked and we found multiple aneurysms throughout both kidneys. There are also aneurysms of the mesenteric vessels. We see aneurysms, as I showed the last case, atherosclerotic change, but this is too numerous to count small aneurysms. That typically means a vasculitis, and the most common one that gives you so many renal artery aneurysms is polyarteritis nodosa, a wonderful example. Now, in terms of doing the study correctly, bolus triggering is ideal. If patients are younger, you surely could do fixed delay, maybe at 30 seconds, and start scanning, at the right point for arterial. But older patients, it can be trickier with cardiac output. So bolus triggering or bolus tracking off the patient's aorta works very nicely. Test bolus technique, when you're doing a test and looking at a number, kind of contaminates the field a little bit, takes too long, and with bolus triggering, why bother? Ideally 5 cc's a second, 100 to 120 cc's of contrast. With newer scanners, you can get by often with 80 cc's of contrast. We use Omnipaque or Visipaque. And again, if we're doing scan delays, it's typically about 35 seconds arterial and about 65 seconds for venous. Depending on the application, we'll do single or dual phase imaging. If I need to look at venous and arterial, obviously it's dual phase. But often we'll do dual phase because not only are we looking at the vessels, but we're looking specifically at the organs, and an antecubital fossa injection is going to be ideal. If you time things correctly, your attenuation here was around 500. And if you time things correctly and you scan fast enough, the attenuation is going to be pretty close throughout the entire aorta and its branch vessels. The ability to pick up subtle pathology is really based on a good injection. And you can see very nicely here the images you can create looking at the celiac and SMA with no flow-related artifacts. So a good injection will prevent any of those pseudo lesions. We like to do a millimeter or less. We're doing 0.75 every 0.5. We have a new photon scanner. We're routinely doing 0.8 every 0.6. Again, you want to make a smooth algorithm. And the 3D mapping will include volume rendering, including both classic volume rendering and often cinematic rendering, and then MIP, as well as routine coronal and sagittal views. So putting all of these together, this vascular mapping, becomes very important because looking only at slices will really limit what you can see. Now, I mentioned before the advantage of looking with a CTA at both soft tissue and vessels. So here's a patient with thickening of small bowel due to Crohn's disease. Okay, kind of classic. But then as you go to the coronal view, you can see the prominent vasa recta, the extent of the thickening of bowel. Coronal views make it easier to appreciate the full extent. And then when we go to the MIP imaging, you see the wall thickening of bowel, but you particularly see the prominent vasa recta, not diagnostic of Crohn's disease, but very common in Crohn's, and also telling you the patient's disease is active. And here, as we go from MIP to volume rendering, we again see the prominent vasa recta, but volume rendering is much better at soft tissue imaging, so you really have a really good appreciation of the wall thickening of the patient's distal ileum. Now, in terms of vascular things we can look at, we always look at sagittal views. We make the point to look at the celiac and SMA. Most commonly, I'm looking for plaque. I'm looking for stenosis at the origin. We're looking, for example, at compression of the celiac median arcuate ligament syndrome. But the SMA, we're also looking at the angle. We talk about SMA syndrome when you have a decreased angle, classically described way back when in patients with total body casting. We also see it in patients with weight loss, both in cancer patients and other patients, as well as patients with anorexia nervosa. Remember, two things sit between the aorta and SMA. One is the left renal vein, and one is the third to fourth portion of duodenum. The SMA angle to the aorta is typically around 45 degrees. With SMA syndrome, it's under 25 and often around 10. The distance from SMA to aorta is normally up to 20 millimeters. With SMA syndrome is typically under 8. Now, we do see patients who have narrowed angles as well as narrow distances, but they're totally asymptomatic. For me, in order to call SMA syndrome, now I'm surely going to describe it, but what I will say is SMA syndrome is when I see obstruction of the duodenum. So here the stomach is markedly dilated with lots of fluid. You see the second portion of duodenum there. And as we track across, the duodenum is narrowed right as it gets to the SMA. You can see the left renal vein is also narrowed. Here it is on coronal view, a classic example of SMA syndrome with the duodenum being dilated, very nicely shown. And here it is again. Look at the angle of the SMA to the aorta. It's a few millimeters in distance and under 10 degrees. Again, this idea about SMA syndrome. Here you see the patient's stomach. So again, what you want to do protocol-wise, give the patient at least 500 cc's of water. Ideally, 1,000 would be great. Here's the duodenum. You can see it's dilated right till it reaches the SMA. And that's a patient with SMA syndrome, very nicely shown here on the coronal MIP imaging. And again, shown here as well. Again, the angle is decreased, the distance to SMA aorta is decreased, but equally important is the dilatation of the patient's duodenum. And here's one more example, a mildly narrowed angle, but look at the duodenum being stopped right at the level of the SMA. Just a very, very nice example shown here on the volume rendering and MIP imaging. And again, shown nicely on the coronal views. I think the coronal views are especially helpful when you're trying to show the clinician where the duodenum transition point is, and it's right at the level of the patient's SMA, as shown nicely there. And here it is really nicely shown on cinematic rendering, duodenal folds, and there's the transition point right there as well. And there's the decreased angles, very nicely shown. And finally, one more case, decreased angle, decreased distance, duodenum is dilated, and again, a patient with SMA syndrome. So for us to call SMA syndrome, and it's a good call, now you don't want to overcall it. Again, you'll describe the angles, particularly in cancer patients, might be decreased, but that doesn't mean they have SMA syndrome. It's really weight loss. But you want to look carefully because sometimes they will have symptoms, and that's the reason the patients are nauseous. It's not tumor recurrence, but it's that dilatation of duodenum due to loss of the SMA angle due to loss of retroperitoneal fat. Again, nicely shown in this case as well. So that's one of the things we think about. So when I look at the aorta, I always look at the celiac and SMA. Obviously, in tumors, you want to look for the involvement. But in non-tumor patients, I look at the angles. I want to make sure there's no median arcuate ligament compression. I want to make sure there's no SMA syndrome. And then, of course, we follow the vessels downward because we want to make sure there's no stenosis, dissection, or thrombus. If you look at vessel size, now I don't typically measure vessels. Here's some measurements that may be helpful. Celiac's the largest at about 0.8 centimeters. I do note when vessels are particularly small, you can see if all the vessels, including celiac and SMA, and their branches are small, the patient's often hypotensive. So that can be a very good sign, kind of like a flat IVC or bright adrenal glands, that the patient is hypotensive. Now with intestinal ischemia, and we'll focus on arterial, we look at the presence of bowel wall thickening, we look at dilatation of bowel, we look at decreased enhancement, or even at times increased enhancement, but we're looking at the vessels. Is the vessel patent? Is there atherosclerotic plaque causing narrowing? Is there occlusion due to emboli? Or maybe even due to trauma? So the things we talk about, luminal dilatation, bowel wall thickening, but in this talk, we'll talk about looking at the arterial map. I'm not going to talk about looking at the portal vein and SMV, which you need to do. Obviously, you also want to make sure the patient doesn't have any portal venous gas. And we talk about ischemia and the complication rate and the importance of diagnosis. I think one of the times when people miss things is when they don't study the vessels routinely, particularly early on in ischemia. The findings associated with bowel ischemia, besides bowel wall thickening, really talk about looking at vessels, both on the arterial and venous side. So we're looking for portal vein and SMV thrombus or thrombosis. We're looking at SMA and celiac, occlusion or narrowing, or some other complication in that regard. So here's a nice example, extensive plaque near the origin, but there's no narrowing of the celiac, and there is some narrowing of the SMA due to calcified and non-calcified plaque. Again, the sagittal views are particularly helpful in looking at these patients. Here's a nice example of thrombus in the patient's SMA. This is an easy one because the thrombus extends from the patient's abdominal aorta way down into the vessel. Again, you can overlook it, though unlikely, but the sagittal view makes it very easy to recognize. And you look at the sagittal MIPS, you can see the extent, which is about 3 to 4 centimeters, and then the SMA is reconstituted. Here's another example with a distal thrombus. One thing I've mentioned before in other talks, particularly related to misdiagnosis, if you only look at the proximal SMA, you're going to say patent, patent, patent. You got to follow it distally because the thrombus may not be proximal. It may be just distal. So in this case, it's the distal SMA. You can see here with the circles that is occluded, and you can make the diagnosis of potential ischemic bowel due to embolic phenomena. And again, rotating the images, here's the MIP images, showing you the large thrombus and the importance of being able to recognize this. Knowing the vessel proximally looks really good. The first 6-7 centimeters of the SMA looks pristine. There's not even any plaque in this case. But look at the extent of that embolic phenomena, which led to the thrombus in the patient's SMA. Another example. Here's a patient where we look and you say, SMA looks good. One of the rules I've mentioned before is look at the SMA in its entirety. As you scan down the SMA, you recognize it becomes occluded. So where it looks good for 5 or 6 centimeters, right here, and right here, this thrombus present. So with embolic phenomena, you can see from the last couple of cases, the thrombus may only be distal. And if you're only looking proximal, which is what people tend to do when they look at the axial views, looks good, 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 and they stop looking because your mind kind of plays tricks on you. When you look at the sagittal view, something which maybe is hard to pick up on the arterial axial view is very obvious when you look at the sagittal view. And again, the point we always make is you got to look at the entire SMA, not just proximal, not just mid, not just distal, but look at the entire vessel because you don't need the thrombus beginning on the one case I showed you proximally. The proximal 5, 6, 7 centimeters may look pristine, but you go further down and you see the patient's thrombus. Now, of course, when we look at vessels, we look at bowel. Here's a patient with poor bowel enhancement despite a good injection. I'll show you in what looks like maybe some air in bowel wall here. And then when you look carefully at the sagittal view, there's the extensive thrombus in the patient's SMA. Patient went to angiography. They removed the thrombus. At surgery, the bowel looked good, so the patient had the thrombus removed, and you can see the patient about a week later. They did not have to resect bowel. This patient was very lucky. They removed the thrombus. The bowel became pink right away. And a week later, the SMA looks perfect. So just a really nice example, as opposed to this case where you can see this large thrombus, the really inflamed small bowel, the inflamed mesentery. This patient went to surgery. The thrombus was removed, but the bowel was not in the best of shape. The patient had about 30 cm of bowel resected. Fortunately, the patient survived. So aggressive management, without aggressive management, these patients have high morbidity, high mortality. With aggressive management, the patients typically will do well. And there's another example, left atrial clot or thrombus. And there's the patient's SMA. The patient presented with abdominal pain, and again, the concern was intestinal ischemia, but we can see the source of the thrombus, which is the left atrial appendage, and you can see how impressive the thrombus in the patient's SMA is, and the distal small bowel loops. The patient went to surgery, thrombus removed. The patient did not need any bowel resection. And again, here's just another example, both a PE as well as thrombus in the patient's SMA, very nicely shown, with the thrombus being very proximal in the patient's vessel. And again, you can see it very nicely here. This patient also has infarcts in the kidney. So one point, of course, we always remind ourselves is when you see something like thrombus in the SMA or celiac, you have to look carefully at the renal arteries. You got to look at all the vessels, because a patient who has embolic phenomena can have splenic infarcts, liver infarcts, and renal infarcts in addition to the bowel itself. So again, very important to look at everything. Now, other things we want to look at in more detail will be to look more closely at the SMA. I just showed you a number of examples where the SMA had thrombus in it, and we had SMA thrombosis. But what about SMA aneurysms? SMA aneurysms account for about 5%, a little more than 5% of all visceral artery aneurysms. They most commonly present with abdominal pain and GI bleeding. Typically, they affect the proximal 5 centimeters of the patient's artery. They're more common in men with a rupture rate of up to 38%. Pseudoaneurysms are usually caused by dissection, while true aneurysms are often caused by septic emboli. Some of the things to think about, again, it's men, 5th decade of life, high mortality if not diagnosed, and again, patients present with abdominal pain, so it could be ischemia, it could be colitis, it could be maybe aortic aneurysm. But again, you could see the causes of SMA aneurysms, but you can see the clinical presentation may not be that specific. We talk about true aneurysms versus pseudoaneurysms, with true aneurysms being the weakening of all 3 layers of the artery without rupture, often incidental, often with common contiguous wall calcification, while pseudoaneurysms are caused by injury to the vessel wall with a collection of blood between 1 or 2 layers and adjacent parenchyma. It's often symptomatic, can be caused by trauma or inflammation. There may be adjacent hemorrhage and extensive murothrombus and discontinuous wall calcification. So patients with pseudoaneurysms are more concerning. They also have a more aggressive looking process. So here's an example of an SMA aneurysm, maybe the largest I've ever seen. Look at the size of that aneurysm. This was a patient with Loeys-Dietz syndrome. Here's another patient with branching off the SMA with an SMA aneurysm. Again, it kind of has some calcification. Patient's older. If you look carefully at this patient, you're probably going to see other aneurysms as well. Here's another case with a smaller mid-SMA aneurysm near an area of thrombus with some narrowing of the SMA, but you very nicely see the aneurysm. This patient presented with abdominal pain. It's a challenge to manage these patients. Do you put stents in? Do you resect? Potentially, can you embolize? It's often a difficult choice in these patients. Another example, abdominal pain. This is a good example of why non-contrast scans aren't good. The non-contrast scan shows celiac and renal arteries, the kidneys. Nothing really impresses me. When you give contrast, there's a definite dissection in the patient's SMA, which tracks down the length of the vessel, and you can see the full extent of the dissection. It wasn't proximal, it was about 3 or 4 centimeters in, and then extends for over 5 centimeters. It's very important to recognize that most vascular things, I understand on non-contrast you can see an aneurysm when it's large, but dissections, small aneurysms, vasculitis, you're just not going to appreciate in most cases unless you give IV contrast. Now, lots been written about the fact that IV contrast has very little reaction rate, that patients do well even with lower creatinines and BUNs. Anything above 30 is good. So use IV contrast, even if you have to decrease the volume just a little bit. Here's that same patient with dissection and the beating and irregularity of some of the jejunal branches of the patient's SMA. Again, very nicely seen. Focal dissection also present and shown well in the patient's mid-SMA. In this article by Jung talking about splenic artery spontaneous dissections, intimal flap, thrombose, false lumen, and aneurysmal dilatation are the most common CT findings. Just a very, very nice example. And this article by Godesera makes the point about the importance of CT angiography in looking at the SMA because it may be the reason the patient presented to the ER. So I have a little bit more I want to speak about SMA syndrome. a little bit more, I want to speak about the SMA in general, and particularly as it relates to ischemia. So let's do this. Let's take a 5-minute break and come back, and let's do part 2 of this series. See you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.